So thank you everybody for hanging in for this last day of this wonderful conference. This is a tough show to follow. Thank you, Dr. Mason, for that. Actually, Dr. Mason was one of the inspirations for me to do what I do right now, so it's kind of neat to be lecturing after her. But so I am Dr. Sotero Rivera. I'm an assistant professor in dentistry and oral surgery at the University of California at Davis. And today I'm going to talk to you about our long-term experience in our institution using mesenchymal stromal cells that are adipose tissue derived for the treatment of feline chronic gingivostomatitis. So this disease you've heard about already in these 3 days of lecture from Nopani, who presented her work with Gallant. It is a devastating disease that happens in up to about 26% of cats, so a pretty big number of cats, and it leads to very severe, moderate to severe inflammation of the oral tissues, not only the gingiva, but also the back of the mouth, inside the cheeks. The tongue can be affected, as well as the lips and the nasal planum. And it definitely affects their quality of life, and it can be life-threatening for certain patients. The etiology appears to be multifactorial, immune-mediated in nature, but also there seems to be some contribution for infectious diseases, as well as perhaps some genetic differences in the patients that are affected. And we always thought of this disease as being something that was only affecting cats locally, but as we learn more and more about this disease, we now understand that there are some systemic effects in these patients too. So locally, in addition to that pretty horrible inflammation that you saw in the picture in the slide before, you will find that these cats have tooth resorption, as shown here on this radiograph. The tooth kind of looks like it's been eaten away by a little mouse in there. And when you look at these patients' histology, the affected tissues show a lymphoplasmacytic inflammation, where you see B cells concentrated in the submucosa and T cells, usually CD8 positive T cells in the epithelium. So our group has looked at viral infections associated with this disease. We did metagenomic and metatranscriptomic work, and we found that feline calicivirus was present in 92% of the affected cases. So no other microorganism or virus was as highly associated in the relative abundance in this disease. And we also found that in addition to possibly being associated to the etiology of this disease, it can, in combination with foamy virus, modulate the disease and be a prognostic factor in that patients that have both foamy virus and calicivirus infection were less likely to respond to extraction treatment or surgical treatment. And another group has also found that feline leukemia virus can also be a negative prognostic indicator. Most recently, a group on the East Coast did some transcriptomic work on affected tissues from patients with FCGS, and they found that these tissues showed upregulation of IL-6, IL-17A, and myeloid lineage enrichment. And taken together, all of these findings suggest that there, again, can be a possible genetic variation in these patients that could be contributing to the disease. So considering all these recent facts that have come to light in the possible etiology and modulation of this disease, in our group we use this diagnostic and treatment approach, and I want to mention that we do all this work with the intention of trying to improve the quality of life of cats, and hopefully we'll get to a point where we don't have to extract teeth in cats with feline chronic gingivostomatitis, but we're still not there. The gold standard of treatment continues to be near or full mouth extraction for affected patients. And even after doing that, 30% of those patients do not respond. And that's where we reach out to regenerative medicine for medically managing these patients that are not responsive. And so we immunomodulate them, usually with mesenchymal stromal cells. Other groups use interferon. And when these patients don't respond, our salvage option is usually immunosuppression. And so in our institution, mesenchymal stromal cell therapy has been used for treatment of refractory patients that don't respond to full mouth extractions, feline chronic gingivostomatitis over the past decade. Dr. Arce has led these studies where he's used autologous or allogeneic adipose-derived mesenchymal stromal cells to treat refractory patients with feline chronic gingivostomatitis, and the success rate has been close to about 65 to 72% success. So there's been 3 major trials. The third one was a multi-center study that also validated the successful shipment and administration of these cells with a similar success rate to those that were produced locally at our institution. But when we look at all these studies, definitely it has increased our knowledge on how we manage this disease, but we have only followed them up for 6 months up until now. So that was the impetus for this project. We wanted to understand the long-term outcome of treatment efficacy and safety of adipose-derived mesenchymal stromal cells for the treatment of cats with feline chronic gingivostomatitis. So this is a retrospective study. We had 47 cats that have been treated in our institution, of which 38 met inclusion criteria. 16 patients were declared deceased, and the other ones we just didn't have sufficient follow-up to include. Follow-up for these patients varied anywhere from 2 to 9 years post-initial administration of cells, and the patient age at follow-up varied from 6 to 15 years. So we performed the follow-up. It was client-based. We had 29 clients that answered our survey that was designed on Qualtrics, and it had 13 to 19 questions, depending on some questions prompted the system to eliminate, some answers prompted the system to eliminate some questions so that we could hopefully not bother clients as much and have a higher return of the survey. And of those 29 people that answered the survey, we had 7 families that were willing to bring back in their patient for follow-up long-term. Looking at the owner-ranked severity scores, we had a positive response rate for adipose-derived mesenchymal stromal cell therapy of about 66%, from which autologous cells had a higher response than allogeneic, though that wasn't statistically significant. So when you look here at these pie charts, what you'll notice is that before treatment, most of the clients consider their animals to have moderate to severe disease manifestations, but after treatment, a huge portion of these patients actually were considered to have mild to moderate disease. And so overall, after treatment, a severity level of 2 was only seen in 19% of patients, which is consistent with the response rates that have been seen in our trials before. The results also showed that owners described their response as a permanent response in close to 59% of patients. Some patients had a transient response when looked at long-term, and those were about 17% of patients, and we didn't see any improvement in about 24% of patients. For those patients that actually came back in for an in-person evaluation, we were able to evaluate their oral cavity and compare their stomatitis disease activity index, which was the objective criteria used in the previous studies performed by Dr. Arce to evaluate these patients. And so what that stomatitis disease activity index does is it takes into account the owner perception of the quality of life of the pet at home, including appetite, grooming activity, and activity level in general, as well as the veterinarian's evaluation of these 9 points in the oral cavity and their inflammatory, the inflammation severity. And we compare that before treatment, at 6 months after treatment, or at the end of the previous clinical trials, 18 months after treatment, as well as at the recheck that we performed last year. And when looking at those 7 patients that came back in, we noticed that all cats experienced a reduction in SDAI after receiving mesenchymal stem cell treatment, and the average reduction was about 83%. Interestingly, when we look at that monitoring tool, the SDAI, sometimes the opinion of the owner wasn't consistent with the appearance of the oral cavity, so that though the system works for monitoring over a long term and when the same veterinarian evaluates the patient consistently, it does need some refinement to be able to consider the owner's perception of the patient's quality of life at home and make it more, more consistent with that. So we then evaluated different variables in relation to treatment outcome to determine if we could hopefully predict who would respond to mesenchymal stem cell treatment. But what we found is that the status at 6 months was the only predictor of long-term response. So the status means if you had no response or partial response at the 6-month mark, you were probably not going to be a responder long-term. If you showed substantial improvement to resolution at 6 months, you were more likely to be a permanent responder long-term. The other factors that we evaluated weren't statistically significant. We looked at the adverse events for all these trials, short-term and long-term, using NIH guidelines, and we found that those that occurred during and immediately after treatment, within a period of 6 hours, were the most common, and specifically transfusion-like reactions were most common, and that included rapid respiratory rate, heart rate, and some nausea or vomiting. And autologous treatments have had a higher likelihood of having these responses as adverse events as compared to allogeneic. Important to mention is that these cases responded to just symptomatic care and resolved within 15 minutes of either providing these anti-nausea medications, diphenhydramine, or just slowing down the rate. Nobody had to stop the infusion, and no treatment-related deaths occurred. Then we worked with the primary care veterinarians of all these patients that received the treatment to gather as much information as we could of potential comorbidities that occurred long-term. This is limited by the quality of the medical records that we received, which in all honesty were largely either inconsistent or had some gaps in time and information recorded. But overall, we noticed that in the patients that were treated with mesenchymal stromal cells, there was a higher prevalence of anemia, cardiac disease, and a slightly increased prevalence or frequency of gastrointestinal disease. However, if we were to gather a more complete data set and more information with a bigger group of patients, we could probably see any sort of different shifts in this finding. So important to know is that client satisfaction was very high with this treatment. So about 91% of clients are willing to pursue this treatment again if a similar situation arose. So we definitely want to evaluate all these objective criteria that we do in the bench, but we also want to consider the client side, because ultimately those are the ones that are going to be coming to seek out your help. So it was good to get a better understanding of how clients are feeling about this treatment option. And when we looked at the factors of their decision making, 90% of them would consider it again because of how well patients responded to the treatment, clinically or grossly, or a combination of both. Also, they wanted to pursue the treatment again because of the lack of other treatments that could potentially work in this condition, as well as the ease of administering oral medications, which I think what it reflects is the lack of need of additional medical management or significant medical management after receiving this treatment because of the high response. So to summarize our findings, we found that systemically administered autologous and allogeneic adipose-derived mesenchymal stromal cells produce a marked and permanent improvement. The success rate was higher for autologous than allogeneic, but that was not statistically significant. The therapy appeared to be safe with no long-term adverse effects, and the patient's clinical response at 6 months post-treatment predicted the long-term positive response of to this treatment. And also importantly, the client satisfaction for the therapy was vastly positive. Some ongoing work in our group involves the isolation of extracellular vesicles from adipose and placental-derived stromal cells. We're going to continue working with this treatment, but on an immediate intervention, so administering the cells at the time of extraction treatment rather than making patients wait for those 6 months before we start treatment, and biomarker discovery for treatment stratification of these patients, seeing who's going to benefit from extraction alone versus extraction plus mesenchymal stem cell therapy. And lastly, Dr. Niarski is going to be working on making these stem cells go stealth mode. And with that, I'll take any questions.
All right, we have time for one question.
No pressure. Thank you, Maria. I was just wondering, with some of the transient responders, were they ever given subsequent administrations of stem cell therapy? Is there a reason why we wouldn't do that?
Yeah, we didn't, good question. So the question is, for the transient responders, did we retreat with stem cells? No, we didn't, but there are future studies that will consider that and will have the ability to be retreated. Those patients were then medically managed, usually with immunosuppressive treatment, because the interferon's not FDA approved in the United States. It's not as easy to obtain and use. Thank you, everybody.